Let's talk about stenosis today, and stenosis of the spine in particular. And my gist of what I'm saying is that stenosis should be a clinical diagnosis confirmed with imaging, not an imaging diagnosis. So stenosis refers to the narrowing of an opening, and this can occur in myriad places in the body, and various things can cause a narrowing to close up. When we talk about the spine, we're almost always referring to a bony narrowing, meaning osteophytes or bone spurs, or that the bones are approximating because the disc that's there as one of its jobs to be a buffer to create that opening, the disc is narrowed via a drying out desiccation process or degenerative process. So stenosis can also occur because of a soft tissue that's encroaching on the space. Inflammation can also encroach on the space. But we're typically talking about bony changes in the spine, which close the holes where the nerve roots exit and put pressure on the nerves, typically on the left and right side, where the holes are called neural foramina. Foramen is the singular, foramina are the plural for those openings. There's also a phenomenon of central canal stenosis. But typically these patients are going to complain of bilateral below the knee leg symptoms that are consistently produced with walking. Now, that presentation can also occur in other people, so that presentation tidbit alone does not automatically rule out everything else, but it does rule in a possible stenosis. I'm going to use the word typically a lot because it's what's true. There are cases where you can have a stenosis where the presentation is thigh pain, but most of these patients are having this predicament below their knees because most of these problems are lower lumbar, L4, L5, S1, and their nerve roots innervate or send symptoms below the knee. So I'm going to use the word typical a lot. I know it's redundant, but it's because these things are not always 100%. Now, the person is usually not going to have pain sitting or lying, but that consistency with walking is abolished with sitting and then resumed again when the patient walks X amount of steps. So when I take a verbal history, what I'm listening for is primarily with the patient where I'm concerned if the pathophysiology or the pathoanatomy is stenosis, is that consistency factor. I need to hear it. I need to hear that every day I go for a walk with my dog and by the end of the block, my legs are killing me. Not some days it's there and some days it's not, because a bone doesn't change, right? A structural change like that, a bony change like that is not going to vary Monday to Tuesday, but inflammation can vary based on the source of the inflammation, and soft tissues are more malleable, so they can vary day to day. So I'm really trying to hone in on that consistency. And in the clinic, when we take the baselines, I would love to use that as a functional test, meaning if it's reproduced within a minute or two of walking, let's go walk and try to reproduce it, because we can use that as a functional baseline for our test, retest analysis when we do the repeated movement testing in part 3. So part 1 is the verbal history. And a lot of clinicians, especially clinicians who only do 6 or 10 minute evaluations, hear that consistency, or they don't pry enough to be like, are you saying it's absolutely always the same? Then they just jump to imaging. Another thing I'm listening for, by the way, in the patient's verbal history is that it came on gradually. It doesn't just start all of a sudden. It takes time for those bones to form, and you would expect that the nerve would get a little irritated before it got irritated to the threshold where the patient was seeking care. So second part of my exam is taking the baselines. So range of motion, strength, nerve tension, functional baseline. I wouldn't expect neurological findings really strongly in a stenosis patient, just because the nerve isn't always getting irritated. So I'm not going to go into the full history of the mechanics, because what's more important is the repeated movement testing. So let's go to part 3, which is the repeated movement testing. So commonly with spine patients, I'm going to look at sagittal plane motions first, almost always, which means flexion and extension. So what would I expect if there's a bone closing down that foramen or those foramina and I extend the patient? Well, when we extend the lumbar spine, let's say the lumbar spine, not the neck, when I extend the spine, those holes close. So if it's already limited in space and we make the space smaller, I would expect that repeatedly moving into extension would produce the patient's symptoms in extension, but once we stop the extension, the symptoms would go away. And we can look at extension in standing or extension on the stomach, kind of pushing up or propping up on elbows or on blocks. Now, if we looked at flexion of the low back opens those foramina, I would expect the patient to have no symptoms because they don't have symptoms at rest and sitting. So if we flex and sitting, nothing should change. And they shouldn't lose range of motion or the baseline shouldn't change at all. So that's what I would expect if the bone were the problem. So many times I see patients who've been given an imaging diagnosis of stenosis who respond well with extension. So something else must be causing the patient's symptoms, because if we were closing the hole where the bone is, the bone, if it's causing the symptoms, that would become even more compressing of the space and cause more problems. So the repeated movement testing really is the part of the evaluation where I can confirm or deny a hypothetical diagnosis. So even if the patient already has the image, I'm not scared to look at extension. I'm always thinking about safety and appropriateness. But again, going into extension, if it temporarily creates the pain that quickly subsides, that's not dangerous. You need that intel, you need that information. And what is it telling us if we extend the patient and everything gets better? Again, it's telling us that something else, possibly soft tissue like discal tissue, or possibly something else mechanical that we can't quite put our finger on, because understanding the mechanics of these joints is a little bit tricky in terms of mechanism. But directional preference, I see all the time, which is cause and effect. We move you this way and your range of motion, your strength, your function, your nerve tension, your symptoms, they all get better. And we don't know exactly mechanically what's happening in those patients, but we have ideas. One of the theories is the dynamic disc theory, which I subscribe to, which says that discs move posterior and anterior and laterally based on the pressures applied to them, the nucleus of the disc. And so moving in one direction theoretically helps take pressure off that disc and restore mechanics to normal. But if we move someone into extension and everything gets better, well, then that disproves that the bony stenosis was causing the symptoms and that this patient's diagnosis is actually joint derangement, which is a diagnosis put forward by Robin McKenzie and treated by moving into the direction repeatedly that helps that patient. So I am very fearful that people are getting an imaging diagnosis of stenosis and calling it a day, right? Opting for surgery because surgery is the only thing that fixes bones. Although we could make the argument that over time, if it hasn't gotten too far gone, we can reduce the bone spurring, but we probably can't prop up the disc again with conservative measures. But for most patients, surgery is the only thing that fixes bones. And so they're opting for surgery, or they're going to a clinician who just says, oh, you have stenosis. In order to provide more space to that nerve, we're going to bend you forward, which should not really have much long-term carryover in terms of the walking tolerance, but it might provide some type of relief. We need to do repeated movement testing in the patients where it's safe and appropriate, and for clinicians who know what they're doing, to really tell us what is actually happening at the level of the joint. Because I don't disagree with the radiologist or the MD who shows the bones on the MRI. I believe they're there, just like we know that meniscal tears are there and rotator cuff tears are there, and ligament dysfunction or changes in ligaments can be present on images, but they're not causing symptoms. So just because a bone is taking up space doesn't mean that that nerve is not getting hit by something else that's not visible on a static image that's just a picture in time. The essence of repeated movement testing is that we move hundreds to thousands of times a day, and and we're constantly in everything we're doing, sitting, walking, standing, lying, asking our joints to do something, to be in a certain position. So the essence of repeated movement testing is you don't know how the body is behaving until you ask it to behave, until you really move it. Snapshots or pictures in time have their time and place. It's usually after trauma, but otherwise, in nearly all cases, I believe we should be repeatedly moving people according to the algorithm of repeated movement testing, which clinician has to learn, and it's usually carried over at home. 30 or 40 repetitions in the office is not enough for me to really know. We need hundreds of repetitions in a safe manner at home to understand what's really going on. So the other problem is if people get this therapy that's somewhat helpful by doing flexion or strengthening or planks or whatever it is, they're just deciding to live with the pain, and that's not an outcome we want as well. So effective care starts with the right diagnosis, and what I am suggesting to patients, especially those who think they may have stenosis or who present with leg pain with walking or with any symptom presentation, I encourage patients to think outside the mainstream box of orthopedic, which is an image tells us everything. Look for a clinician who understands that imaging can be useful, but there's a minor role for it to play, especially in non-traumatic injuries. And look for a clinician who's curious and understands how to move the body to get the most reliable diagnosis possible in order to then figure out the appropriate matched treatment.